Good afternoon, everyone. A very warm welcome to all our participants joining us today for the third installment of our webinar series, Understanding Practical Bioethics. My name is Vijit Sangma, and I'm your host for this afternoon. To begin this session, I would now like to request Dr. Ronald, who's the General Secretary of CMAI, and to just say a word of welcome and do the opening prayer. Over to you, Dr. Ronald.
Thank you very much, Abhijit. I bring warm greetings from the Christian Medical Association of India, and it is really an very important topic that we're discussing in the series. And I especially want to thank Dr. Jeyaraj Pandian, who's our resource person for today, as well as Dr. Rupa Verghese, who's going to moderate the session, and my colleague Abhijit for organizing this as well. I think the previous sessions has been very, very beneficial. We've get a lot of response from all across the country, even from outside, and it's also something that is very relevant to the current situation where ethical dilemmas are increasing day by day with various things, and especially this topic on ethical consideration of end of life care in neurological diseases. Is something that many people are struggling with, and I hope that this session will give us a better clarity of the subject as well. So I warmly welcome each and every one of you, and thank you for your time and taking out your time to attend this session. Shall we look to the Lord in prayer? Heavenly Father, we thank you for this time. Thank you that you have brought us together to discuss, to listen, to discuss, and deliberate upon a very important ethical dilemma, one of the important ethical dilemmas that we have in our current situation. We hope that, Lord, we ask for your prayer, we ask for your wisdom, we ask for your guidance, and we ask for your protection during this session. Whatever we do, the Lord, may help us to understand your will in our lives and how your will for the healing ministry is for us. Lord, I commit everyone, especially the resource person, the speaker, and the moderator, and the organizers at this time. Lord, be with us. May your Holy Spirit make us understand these important topics. Lord, we commit everything into your hands, all the technical uh, things that are a part of this, as we are having online. Lord, we commit everything unto your hand. We praise you and thank you. In Jesus' name I pray. Amen. Over to you, Abhijit. Yeah.
Thank you, Dr. Ronald. As many of you who have followed this series know, the goal with understanding practical bioethics is to move beyond abstract theory and provide healthcare workers like you with tools to navigate through the tough decisions faced at the bedside. In session one, we established the ethical framework and the importance of human dignity. In session two, we decoded the shifting legal landscape in India following the recent Supreme Court mandate. Today, we move on to a highly specialized clinical area that often presents most profound ethical dilemmas, neurological diseases, whether it's determining brain death or managing a persistent vegetative state or discussing a stroke prognosis. The intersection of neurology, ethics, and faith requires a clinical, yet a deeply passionate, compassionate lens. So, to moderate today's discussion, we are privileged to have Dr. Rupa Verghese. Dr. Rupa is a senior consultant, obstetrician, and gynecologist who's been trained at CMC Ludhiana and holds a master's degree in bioethics from Trinity International University, Chicago. He brings over 20 years of experience serving in remote clinical settings with Emmanuel Hospital Association and has held leadership roles in corporate healthcare as well. Currently, she serves as the executive director for the Center of Bioethics. And our resource person today is a global leader in the field of neurology. My distinct honor to introduce Dr. Jeyaraj Pandian. Dr. Pandian is the principal and Professor and Head of Neurology at the Christian Medical College, CMC Ludhiana. He is also current President of the World Stroke Organization. His extensive work in stroke care and neurological research has gained international acclaim. He is uniquely positioned to guide us through the complex ethical challenges found in neuro ICU and beyond. Dr. Pandian, we are eager to learn from you and your expertise. Now I hand over the floor to you and Dr. Rupa. Over to both of you.
Thank you, Abhijit, and a very good evening to everyone, and welcome to our webinar on practical bioethics. As Abhijit mentioned, the third and the last in this series of the end-of-life ethics and clinical decision making. Today, we would be discussing how we would be navigating complex neurological scenarios. And like how he mentioned, we've been exploring the complex issues of end-of-life care in our previous discussions, and we've discussed the importance of ethical decision-making in the clinical practice. Especially, we discussed about withholding and withdrawing life support, the critical aspects of the end-of-life care that requires careful consideration and compassion. Valuable insights were discussed on these topics, especially highlighting the nuisance of clinical decision-making and the importance of respecting patient autonomy. In our last session, even though we started with discussing the Supreme Court decision, but we have explored on the ethical consideration and the legal aspects, how it can be intertwined when we come to the end of life care and the legal frameworks in the legal frameworks that guide our decision making. So now, building on those discussions, today we'll be diving into a bit more complex scenarios, rather practical scenarios in the clinical consideration for end-of-life care in neurological decisions. And we'll be exploring the complex scenarios that a clinician faces practically, discussing from prognosis to maybe navigating into palliative care. And like introduced, who better than Dr. Jeyaraj Pandian to help us guide with all of this. Thank you, sir, for being a part of this. And sir, my first question to you would be, in a progressive neurological disease like ALS or muscular dystrophy, anything, how should we approach the discussion of care plans with patients and families regarding life support once we've seen that sustaining life is not possible without this?
Yeah. First of all, I thank the CMAI and the Bioethics Institute and also the CHSR for inviting me for this important session. So when I look at neurological disorders, these disorders are the leading causes of disability-adjusted life years lost. And globally, if you look at among all the diseases, neurological disorders lead to a lot of disability. And for example, if I start with motor neuron disease, we have a couple of types, ALS, then we have Parkinson's disease, dementia, stroke, and muscular dystrophies. And there are several degenerative neurological disorders. And so the end-of-life care depends upon the type of neurological disease that we are dealing. For example, if you look at motor neuron disease and the classical amyotrophic lateral sclerosis, if the onset is from the limb, either the lower limb or the upper limb, the median survival is about 3.5 years. And if it is from the bulbar, the lower cranial nerve muscles, there the median survival is 2.5 years. On the other hand, if you look at degenerative disorders like Parkinson's disease, it is a late stage. After 7 years, 10 years, they go into that late stage of the diseases. Similarly for Alzheimer's disease as well. And if you take muscular dystrophy, the three common muscular dystrophies are DMD, Duchenne muscular dystrophy, and facioscapulohumeral muscular dystrophy, and Becker's muscular dystrophy, and several limb girdle muscular dystrophy. There also, again, it is variable. And among all the neurological disorder, the one condition where it is of acute nature in decision making is the stroke, where you have a large ischemic stroke, and there, the end of life care comes in very early, and a large intracerebral hemorrhage. So it depends upon the condition that we are dealing when we are looking at um, the care plan, etc., and how we are going to deal with it. For example, for acute stroke, right in the beginning, when we look at for example, if there is a big malignant MCA infarction or brainstem stroke, when the entire pons and the midbrain and medulla is affected, the person will be in deep coma, vegetative state, or completely, unresponsive. So those patients immediately you need to take a decision whether to continue the life support or not. And in big hemorrhages, it may take some time. So if I start with stroke, the care plan depends upon what type of stroke, the severity that we are dealing with. And usually, we try to take at least 2 to 3 days. We explain the poor prognosis. We say these are the lines of treatment that we will try. In 48 to 72 hours, if there is no response or no improvement, then probably we take them through the end of life care, withdrawal of support that we will discuss later how we can do it. And for muscular dystrophy as a whole, the care plan should be, with the recent advances in treatment and looking at the conditions which can lead to sudden deterioration. For example, if you take Duchenne muscular dystrophy, you have corticosteroids which can reduce the rates of cardiomyopathy or occurrence of cardiomyopathy. And there are drugs like ACE inhibitors, even some of the mineralocorticoids we could use to reduce the fibrosis of the heart muscle. So that is one area. If we take care, they live longer because their cognitive functions are fully preserved, and we can provide them support to prevent contractures, etc. And have, with a lot of assisted devices that are available, they can be, independent with support and do all sort of cognitive work, even education, etc. And for ALS, when in a neurology circle we say that, if we make a diagnosis of motor neuron disease, that is a death sentence. And even there are advances in treatment, but um, right from the beginning, there we need to have the care plan. Whatever available drugs that can delay the progression, we can try, like Edaravone. Some people have tried rituximab and immunoglobulin, and more drugs are in pipeline. And but from the limb onset, they will have bulbar symptom. That is where we need to caution them about choking, dysphagia, and nocturnal hypoventilation in the night, and then take them through the final phase of end of life care and palliative care. And so, in a nutshell, that this care plan differs from different neurological diseases. And for example, in dementia and Parkinson's disease, is going to be at a very late stage.
Thank you, sir. So in your experiences, do people with such progressive conditions opt for an advanced medical directive, or is it something that should be introduced and discussed with patients?
Yeah, the advanced health directive as a concept, it is pretty new to India. I don't know about southern India, but in North India there is no concept at all. Even though there is increasing awareness about organ transplantation and donating one's body after they die. There are some social awareness, which is improving, I would say, but advanced medical directive has not evolved, I would say. But maybe there is an opportunity to introduce this advanced health directive when we make a diagnosis and have the care plan and have the decision upfront. We could guide them, how it can be done, how as a living will they can document, and the process that is involved, how in the affidavit and the notary public, and how it can be handed over to the guardian where the legal specification which are there. It can be done when a diagnosis is made, particularly for degenerative diseases. And Duchenne muscular dystrophy is very sensitive. Children are involved, and where you can't upfront talk to the parents. Where there are the life expectancy of DMD children has increased by 20-25 years with the current treatment. So the best place is for degenerative neurological disorders where upfront we could do, and also malignancies, of course, cancer, brain tumors, etc. We could plan that, and we can help them, in that process. But otherwise, like overseas in developed countries where a patient comes to the emergency, first thing they look at is in their electronic medical record, do they have a advanced health directive? Most of the time the relatives are not there, they are not contactable, so you need to depend on the electronic medical records or in the patient's records or GP records where they have attached the advanced health directive. And if it says that don't want any intubation, and it's very clear even in the emergency with that documentation, people won't proceed with treatments which they are said we don't want. And it's very important to bring into Indian context, and many of the conflicting situation we could avoid, in an emergency situation. And like, for example, somebody healthy and they have this living will that, in any condition, whether it's neurological or any medical surgical condition where they may end up into a ventilator and they may not improve. And if you have an advanced health directive, it's so easy to take a decision. Yeah. So there's a big scope, I would say, for this advanced health directive.
Yeah, so basically it is there in India, but we are not able to practice it directly, so well on directly, because we don't have an electronic medical system where all the hospitals would be attached and we would be able to access it. So I guess maybe patient to patient wise, and once we made the decision, and then get it across to them, because most of the time our relatives are accompanying us, whether it be the distant one or the near ones. You would have some relative who would be walking in with the patient. That's true, sir. So,
Yeah.
sir, let's say in the absence of AMD or an advanced medical directive, so how should a medical practitioner approach this end of life decision making in a patient, especially if it's a progressive disease?
Yeah, I think I will take you through what is available now and what is being done in healthcare setup. So there is a discordant there. Even though we have the Supreme Court guidelines, and ICMR also is published. So when we have a situation where AMD is not available, then first step is assess the neurological condition, whether it is reversible or irreversible. That is very, very crucial. And if it is a chronic neurodegenerative condition, you need to look at the severity of disease. If it is a dementia, if it is Alzheimer's, whether they are in a severe stage or late stage or advanced stage, we call, even if it is Parkinson's disease, whether they are in the late stage, whether drugs are not working, and they are completely dependent, bedbound. And of course, in acute stroke, it is very easy, the decision making. So when there is no AMD, first is the irreversibility of the condition, whether we can reverse that problem. For example, a patient with a Duchenne muscular dystrophy, 20 years, rather doing very well, good quality of life, performing very at a higher level, particularly in terms of cognition, and then suddenly they come with a chest infection. They can just go downhill. And so those conditions are reversible. We need to really first decide, that is the first step, and then discuss with the patient, if the patient is conscious, or the relatives. That is probably the second step. And the third is, we need to take an informed decision-making process. Sometimes immediately it is not possible, and for the relatives to get into their thought process and deciding. Sometimes 1 day, 2 days, sometimes it may take a week, or they may say, let us try for a few more days, and then so we need to really give a good amount of time for them to decide. Once they have made a decision, then I think we need to really document. If the typical end of life care, withholding life support, if it comes from them, then the hospitals need to have this primary board, secondary board, and inform the chief hospital administrator. First, bring in the primary board. I think basically four physicians, one treating doctor, one MS, and other two are from other departments. And they need to really document whatever the physician has brought forward, and the relatives. And within 48 hours, they submit, and then the secondary board with a CMO, you on board, and then both the decisions are given to the hospital administrator and then to the court. But this is the process, but it is very impractical. Okay, at the hospital level, you can manage, but beyond the hospital, for example, the civil surgeon has hundreds of things to do. And even though they may have a committee or nominated person, but it is practically very, very difficult. So, yes, the law is there, we need to follow. But most of the time, what happens is, I would say, a shortcut. No, where even without constituting the primary and secondary board, when we clearly know that it's a irreversible condition, uh, the ICMR also has guidelines. Do not resuscitate, and most of the hospital, this is what is being done, where they go into the DNR, and even if they are on ventilator, no, you don't give them vasopressors, don't do invasive procedures like, for example, invasive treatments like if the patient has acute renal failure, and don't do dialysis. So you try to withdraw some of these intervention which can prolong their life unnecessarily, when we know that it is irreversible. So this is what it happens. We have the process in place, but that doesn't happen in all the hospitals. Yeah.
So, basically, the current treatments, most of them, we wouldn't be able to put them under curative, right? It would
Yeah.
be it would be, most of them would be supportive at different levels of support, like you mentioned. Like you see the condition and then decide how it can be a reversible or an irreversible condition, and then decide and take forward from there as to how would make a decision, right?
Yeah. Yeah,
So,
absolutely. Yeah.
so what would be your suggestions on, maybe on a practical level, to form some protocols or pathways if in case we do start a treatment, but let's say we know that there is no, like you don't have a directive, and you do know that the patient has some problem, but right now he came with, like you said, somebody with DMD but came with a respiratory failure, and you thought, okay, fine, let's start with the treatment, and you just put him on a treatment. Now you know that it's not really getting better. So what is the pathway that you would suggest that we can practically use for withdrawal of this support, so that the quality of life and the burden is accept like when you know that this is not acceptable, like continuing support is not acceptable, like
Yeah.
practically, how would you say that?
So I'll give you a few examples, then you'll be able to understand better. So a resident on call, a junior doctor, in the night, a patient with ALS, or this has happened many times, ALS and DMD patients coming with respiratory failure and gets admitted, and they intubate the patient. And this is a very difficult situation for a emergency medical officer. Patient is gasping, and then you can't be saying, "You're a ALS patient. I can't do anything." And there's no reversibility, and but that is again the ethical dilemma there. Patient has problem, and we know it is irreversible, but putting them on ventilator, that person may or may not be knowledgeable, and so you intubate and find out what is the cause of the respiratory failure. Is it the primary neurological diseases, or it is some infection? Usually, it's a pneumonia which they aspirate and then have pneumonia and then when go to respiratory failure. So you intubate and treat. That is where once we come to know that usually DMD patients, if you treat the infection, they come out, but ALS patients not like that. And even if they have infection, and if you intubate, once you intubate, we may not be able to take them out of ventilator. We have had in the past many ALS patients on ventilator for 2 weeks, 3 weeks. So difficult to decide with the relatives. So in a situation like that, I think try as much as possible, to treat the reversible problem that triggered, that event. If it is not reversible, the worsening of the neurological condition, then we need to take them through the same process of informed decision and withdrawal of support. Uh, Try not to give new treatments which can unnecessarily prolong their life, and particularly the pain. That is where the palliative care comes in, taking care of their secretion, taking care of the bowel, the dysphagia, pain. No, that is because they won't be able to express. You keep on poking them, multiple lines, central line. We can't induce pain in those patients, and so these are the steps I would say. Yes, of course, there are several protocols available for us to use, but when we want to apply in a given clinical situation, it has to be case by case. We won't have the typical case scenario that are given in textbooks or journals, and when we suddenly you see a patient, it could be something like we have seen many times in pediatrics, um, patient with muscular dystrophy intubated, and we go for a consultation. So what would you do? So we need to really have a clear discussion and decision making process. Now, sometimes it's very challenging. and not only for us, but also for the patient if he's fully conscious. And all the muscular dystrophy patient will be conscious, and ALS patient will be conscious. So that is where it hits you when you go and see them every day. The first thing you realize is the person is fully conscious, but on ventilator. What will we do?
So, sir, do you have any other support system that you would suggest that we add on other than just the treating physician, or like the number of treating physicians who are alongside with them?
Yeah, I think that we need to bring in, I think as Christian institutions, that is where the spiritual support, for them, uh, you know, and bringing in the chaplaincy department and psychological support is very, very important. But if they need help, we need to bring in for the even for the patients and relatives. And many times these are the two areas. If we take care of these two situations, that gives them strength to take a bold decision. And also nutritional support depends if you want to put a peg or or just feed with NG tube, and so these are some of the other tips that support system that we can build in along with this.
Thank you, sir. So just in a concise, if I could just bring it down, so I could suggest is you see the situation, maybe you start with the treatment, and then over a period of time decide whether it would be a reversible or irreversible cause. And if you see that it is in a deteriorating phase, bring in all the support that is possible. If it's a Christian
Yeah.
institution, bring in people who can give not just the physical support, but emotional and spiritual support as well. And then take them with the protocol of how the life support could be withdrawn or withholded. Right.
Yeah,
Right, sir?
maybe I'll just give one more example of very elderly lady, 82 years, fully functional, had a limbic encephalitis. She had status epilepticus, multiple admissions, at least three episodes of status epilepticus, intubated. But it's a reversible condition, treatable condition. So we went, and again gave all the available treatment. She improved. She returned back to not a higher level of functioning, but with a mild left side weakness. And she was on immunosuppressant, lived for about 4 years. Suddenly came one day with pneumonia and respiratory paralysis. I, we treated her for 2, 3 weeks, but nothing. No, she was not improving at all, and multiple complications. Then we talked to the relatives, and they said, "We don't want our mother to go through this." So then we extubated her. They did not want non-invasive ventilation, and we kept her in the ward. They did not want to be in ICU. Shifted her to the private room, and the relatives spent their time. Probably, she died in 18 hours, but they were able to spend time with her. We gave her some morphine and all the palliative care medication to for comfort. Um, so this is another example of how, in that given situation, no, initially the treatment, the disease was reversible. Later on, developed complication because of the immunosuppressant, and it became irreversible.
So if I could just add one more component, which is the
Yeah,
financial component, which is a
yeah,
huge aspect in the Indian scenario, especially even in settings where a lot of people who are not able to access government facilities or are not comfortable accessing it, let's say they come to a private setup where the treatment is good, but they may not be really in that phase. In those conditions, is there anything that you would suggest elsewise?
yeah. I think this when in the finance part, it is very painful. I would say, for example, acute stroke. A person comes with a large vessel occlusion in middle cerebral artery or anterior cerebral artery or basilar artery. where the treatment, the evidence of thrombectomy, you put in a stent and remove the clot. And it has a dramatic treatment effect. Number needed to treat is about 2.7. And the benefit is so much. And the cost is about, for the entire procedure is about 3.5 lakhs. And after that, you have the stroke unit management, neuro ICU. So, in a nutshell, for a large stroke like that, if they come on time, at least 5 to 6 lakhs will go. But that amount of money, if they put in, it will lead to a good functional improvement, and it will reduce the cost on the maintaining a person with who's disabled. If you look at the cost savings, but to afford that acute treatment, that is where the problem is. And if they don't have insurance, it's a challenge. And in many private hospitals, corporate hospitals, they don't entertain those type of patients. So in Christian institution, like we have a corpus for poor patients, stroke patients who can't afford this treatment, and we have a CSR funding, and ongoing. In the last 3 years, we have been having this funding from a donor. So we try to, put some amount from there and tell them, whatever you are able to afford, you tell us. And then the remaining money we put in there, at least provide the acute treatment, and then decide later, how much improvement they are making, and but it has really saved several lives. So we need to look at ways of bringing in some support system for the finances, and without that, it's not only this area, but there are several treatments, several other diseases where the treatments are very expensive. But as Christian institutions, we need to really take care of that need also, and try to bring in some subsidy or some help from other sources, or like the CMC Velour model. You have surplus, and the departments, every consultant, they have the right to reduce the cost. So I have seen several acute stroke patient in CMC Velour stroke unit. They can't afford the entire treatment is free, it's written off. And so that is where, and as Christian institution, we have a major role to play.
Thank you. Thank you, sir, touching that really important aspect. So if let's say if we've diagnosed now, like a person is brain dead, so do we have a criteria for that? And how do we confirm that? That yeah, actually it's actually brain dead, because that's going to be a really difficult situation, even telling it down to the patients, right?
Yeah. So first, I will talk about the criteria that has been laid down. It is not only for the clinical situation that we face, but also for the organ transplant. So you have a clear-cut criteria for organ transplant and the day-to-day practice that we come across patients. For the organ transplant, it's very clear. You need to demonstrate various clinical signs. Before that, we need to look at again, I mentioned the first step of what is the clinical diagnosis. For example, from the neurological disorder side, it is a traumatic brain injury, whether it's a stroke, and usually this brain death and organ transplant kicks in when there is a TBI. And first is the reversibility of the condition, and then we need to make a clinical diagnosis of brain death. So you start from the brainstem reflexes, the midbrain pons and medulla, the lower cranial lobes. So first is the pupillary reflex, whether pupils are reacting or not. Then you have this dorsal eye movements, by moving head to one side, whether there's a movement of the eye to the other side. Corneal reflex, whether there is any spontaneous respiration. And if it is for organ transplant, you need to do this cold calorie test, inject 50 ml of cold saline and into the one ear, and see if there are any movements of the eye. And the the most important test is apnea test, where you disconnect the ventilator. But before you disconnect, basically you disconnect and try to check the rise in carbon dioxide, that would trigger the respiration if the respiratory centers are intact. And so there are different the baseline criteria. The oxygenation saturation should be normal for that patient, and the BP should be above 100 millimeters of systolic. And so there are criteria, and they should not be in hypothermia. Then you give 100% oxygen, and disconnect the ventilator, and then put a cannula into the endotracheal tube and give 100% oxygen, 6 liters per minute, and for about 8 minutes, and then measure the ABG, and also see whether the saturation improves, and any respiratory movement. So this has to be documented. The ABG, the PCO2 should be more than 50 millimeters of mercury. And so this is the apnea test. There are other tests, for confirmatory tests like EEG, and EEG, no, to 2 microvolt sensitivity. There should be a flat background for 30 minutes. You need to record transcranial Doppler, CT angiogram, DSA. There are very high level nuclear scans, etc. But those are needed only when you are not sure. And but for organ transplant, at least EEG should be there, and you need to repeat it after 6 hours. And there is a medical board you need to constitute, and they need to go through that. And but for example, in a clinical situation where a patient with large intracerebral hemorrhage, in the basal ganglia, they deteriorate very rapidly, where you may not be able to do surgical intervention. And there, fixed people, corneal reflex, lack of spontaneous respiration, and motor movements, to pain, the Glasgow Coma Scale. These are simple bedside tests that you'll be able to do, and then you can document. Even though it says 6 hours, but I always give at least 24 hours or 48 hours time. So suppose a patient with acute stroke comes, and we see that people are not reacting, but it's not dilated. There's some little bit motor movement. We tell them, no, we need to wait for 24 to 48 hours, and every day you assess. And then when you see that there is no improvement, all the other organs are getting affected. No, no, we don't wait till then, but when by 48 hours, if there's no improvement, then we tell them that it is brain dead, and then we take an informed decision making. Most of the time, what happens, at least in this part of the country, they take, I think many other regions of the country also, they take the patient home. There is no clear end of life care. Very few people, because the cost also for them in private hospitals, every day they stay, when there is no benefit, the cost will go up. So for them, the easiest way is when they know that this is the outcome, and they will say, Dr. Saab, chutti kar do. So this is what happens here.
So, how would you suppose, like, we can break this news to the family members, especially the ones who are unwilling to approach? Because that breaking the news would be the first step in case we even want to talk about organ donation or anything. Like, let's say if that is something that we are suggesting.
Yeah, I think it's unlike cancer, no? And if I take acute stroke, and then maybe I'll talk about the chronic the ALS, probably the chronic, one of the prototypes, I would say. ALS, how we decide, and how we break the bad news, and how we break the bad news in acute condition like stroke. And so when they bring the patient to the hospital, unlike developed countries like Australia or North America, Europe, and where the patient is found unconscious, at home or living alone, or the spouse is there, they call the ambulance, they come. Spouse may not accompany the patient. And you do the investigations, um, and then decide. So that is where there are a lot of cultural things that are inbuilt here. In Australia where I worked, where there won't be any caregiver with the patient, and then we need to find out from the file whether they have advanced health directive, the contact number, son, daughter, call them and say that your father, mother has had a big stroke, and the prognosis of survival is poor, and we would like to inform you. Do you want to come and talk to us? And they will come. They will give a time, and then till then we continue the treatment, and then uh, we decide with them finally. But in a situation in India, it is acute. Even though we explain to them, no, it is like, for example, father, mother went to sleep at 10 p.m. Morning they try to wake up, they are unconscious. It's so sudden. So they are not able to grasp what has happened. So they bring the patient here and we do an investigation. And for us, it's so easy. Oh, it was ischemic stroke, hemorrhagic stroke. But for them, it is an acute situation, emotional. They are not able to understand. You may explain, no, this is this, and no, the outcome is not good, and we have to intubate. You tell us what you want us to do, and no, this is a way that we need to give the treatment. But the first thing they'll say, that's up, whatever is good for my father and mother, you do. So the responsibility comes on us. They'll say, whatever is the best that you do. So at that acute moment, they are not ready. We need to take them through. So that is where if they are not sure that they want to intubate the patient or not, they are not giving their decision, just treat them. So that is ethically correct, and do no harm. But uh, do, not giving the treatment also is a harm. So in that situation, you do whatever is capable medically. And then slowly they will also understand. It may take 2 days, 3 days. That is what we have seen. Not all of them are able to take decisions quickly. And I also mentioned earlier, then the cost comes in when they know that this is irreversible, and then they come to the terms and they take a decision. So I think it's very context specific, I would say. It may culturally vary. In Kerala, it could be different. Tamil Nadu, it could be different. And we need to really look at the local cultural perspective. And in North India and this region, for a son and a daughter or a spouse to take a decision for their loved ones, particularly the end of life care, it is extremely difficult. Very easy to say, but it's extremely difficult from their point of view. They have to live with that guilt. For example, if they decide, let us remove the ventilator. But no, they may have this thought, if we had continued, whether my father and mother would have come back, returned back. So, we need to look at their emotional context and what goes through their mind.
The what if question, like it's never answered. It's
Yeah.
very difficult to get that answer.
Yeah.
Thank you, sir. So I think I would like bring this to a little bit of a conclusion. If I could just conclude by putting a few key points, if we could remember that once we have a patient, I guess we first need to discuss the prognosis we first need to investigate and bring them to a level like where we start with the treatment unless we really have a clear directive which says that the treatment is not required. And then once we discuss the prognosis without giving any false hope, even when the outcomes are uncertain, But we put some realistic timelines, like you said, maybe 3 to 4 days, because that's where we come to know whether these changes are reversible or irreversible. Then,
Yeah.
in case we know that it is irreversible, we bring it down to end of life care and comfort care, and that becomes more focused, I guess. And once we have a clear explanation that this is even going to go further, let's say we've diagnosed it as brain dead or with whatsoever criteria, then we have a discussion with the family, with the members, whoever are there. Give them time, give them support, not just physically, not just the medical support, but emotionally, spiritually, and then slowly discuss about if the withdrawal of the support, along with some advanced directives, if it is available, if it is possible, if they understand it, have the medical board on board, and then discuss with them along with the ethical and faith perspective of giving them the support, because it's never going to be an easy, and it's never going to be a simple decision, is
Yeah.
what I would put it as a small synopsis of what we discussed.
Yeah.
So, thank you, sir, for such an enlightening session, actually. Even though most of us would have gone through maybe similar situation in our areas of work, or maybe even personally, but most of the time it's always a question. It's all because it's never a clear line as to where to draw in with, and e- uh, I guess it's just over a period of time. It's with experience. It's with so much of just interacting with people on different levels is where we, over a period of time, we build these protocols, we build these regimes, and we build these thought processes of how to take people across with these problems or these issues. I'll open the floor to anyone who would want to ask any questions. Abhijit, if we have, I think we had a few questions earlier itself. Most of them we've covered, I think, in the session. There was only one, if I'm not mistaken, where we were asked about if there's an unconscious patient for months or years, sometimes with no really hope of improvement as far as medical science is concerned, maybe even old age or other morbid conditions. How much of intervention should they go through? Is it just NG feeding, parental feeding management, or thinking that they would improve on a later stage? What would be your suggestion on it, sir?
Yeah. Yeah, it's a very good question and common problem that we face. So I divide that into two categories. One is because of the cognitive problem, like let's take the example of dementia, where they are not aware of what is happening. They can't recognize the relatives or anyone who comes, and they are completely dependent. And the second one is the persistent vegetative state, which I didn't cover earlier, which is different from the brainstem death, where all the vital functions, the heartbeat, blood pressure, breathing, everything gets affected. But here, it is the cortex, the cerebral hemisphere is mostly involved, and the brainstem is relatively preserved. They will breathe normally. They are quadriplegic basically, and only way that they can communicate is the eye movements. So we need to establish the communication with them, no? Like yes or no answer. So we need to tell them, if you want to answer yes, close your eye. If you want to answer no, then not close your eye. So that is how you communicate. And I'll give one a life experience. When I was in Australia, it was an acute stroke patient, a young person, 35 years old, brainstem involvement, and the pons and midbrain. He was quadriplegic, and he was on ventilator. He was in the emergency department. The only movement was possible was little bit eye closure and a little bit of eye movement. And this patient, uh, it's somewhat conscious. It's not fully conscious, and there is some response. So the wife they had one kid, probably I think 5 years old, I think. In one of their family get-togethers, he had mentioned during a conversation that if he gets into an illness and he's on ventilator, and when it is not, when he'll be left with permanent disability, he had expressed a desire that please do not intubate and remove the life support in a very casual conversation. So this person did not have advanced health directive. So we are stuck, persistent vegetative state. It can go on for months. You need to take care of that person. You need to feed them, and because rest of the organs are functioning well, heart rate, the heart is functioning well, kidneys functioning well. The only thing is they are quadriplegic, not able to move, and only the eye movements is the only way they can communicate. So the hospital created a team, and the wife said, "This is his desire. I want him to be removed from ventilator." It was a young person, and so the hospital had a system. So the lawyer came in, and I examined. We gave him questions like yes or no, no, and to my assessment, he said that no, I concluded that he wanted to continue on ventilator. And there was another neurologist I was a primary neurologist who was managing him. Another neurologist in the team who he had not seen him, he assessed. He felt that yeah, it was no. So we waited for another 2, 3 hours and then read it. So it appeared to us it was no. Whatever little communication he had. And the wife was very clear. This was his desire. And 4 hours later, we removed him of ventilator. He passed away in 15 minutes. So this is one situation, what we call persistent vegetative state. It could have led to persistent vegetative state if we had continued him on ventilator. So this condition, we need to be very careful. We can sustain. We have sustained many patients like this. We put them on an nasogastric tube feeding or a peg, and you have to give all the support system because they just move their eyes. They try to communicate. Some of them communicate. So you have to wait and watch, till the natural thing happens. But in dementia, when they are not aware of anything around them, I think that is where the care plan you need to have a clear goals, and if they're probably with a good discussion with the relatives, we can have a care plan and the decision not to intubate. If there is an irreversible condition, then do not intervene. And so that is where, as the individual patient, we could take them through.
Thank you. Thank you, sir. Abhijit, are there any more questions?
Yeah, it's there on the chat box. You can read. Can you see? Let me read it out then. Thank you for a good overview of the end of life dilemmas. What is the role of early counseling about later stages of this condition? Often doctors delay this in order to allow for hope. Also, a better understanding about possible outcomes in DNR and advanced medical directives and palliation. Though culturally, it is not palatable.
Yeah, I think it's we should really consider this. When we are very clear and you're sure that the diagnosis is correct and the prognosis, we are given adequate amount of treatment, and there probably we could bring in early counseling. But the rest of the things, depends where you're practicing, and accordingly you follow. And like for in this region, um, you know, uh, if you give too much information, they'll get confused. You need to keep it very simple. This is not going to improve. This is what will happen. And but on the other hand, in South India, we need to give all the details. the percentage and everything. So I think culturally you need to be very sensitive to give this information. Yeah.
Yeah, and it would also vary with different places, I guess. So you
Yeah.
are tertiary care center, secondary care center, maybe somebody in the village,
Yeah.
because you would be dealing it at different levels in that way. True. Most of the other questions, I think sir has covered it in different aspects, Abhijit, in his session itself. So
Yes, I think all the questions got covered. Even one of the question which was asked was, what is the role of chaplain in all this? So that also sir has
sir has
responded
covered.
to that. Yeah, sir has covered. So now what I'll do is, I think right now you can unmute yourself, and if there are any questions, you can ask. Or if you have type, if you're not able to type, you can unmute yourself and you can ask, and then Dr. Rupa and Dr. Pandian are there to respond to your question. So in the
Maybe.
meantime, yes, sir, please go ahead.
Yeah, the one more thing which is very interesting, which is neglected, I've learned from this practice. See, in my early days as a career of in the neurology career, I used to be very aggressive on this, end of life care, and bring in protocols. So the one instance where a large stroke and I gave a very bad prognosis. I was so confident that if you disconnect him from ventilator, he will die in 15 minutes, 20 minutes. I was so confident. So with all discussion, and they gave consent, and we removed the ventilator, and the patient is not dying. It was such a patient is breathing. um, so it was a I would say, the terrible situation when, your assessment goes wrong. But after 6, 7 hours, patient died. There's another situation where, why we need to be careful. It's again learned from this hard way. Uh, I sent the patient home. Father had a big stroke, and as per textbook criteria, bad prognosis, not going to survive. And I told the son he will live only for 1 hour, and we removed the endotracheal tube, sent him home. He took him home. Uh, and at 3 a.m. in the morning, he's calling me, Dr. Saab, सांस so ले रहा है, मैं अभी क्या करूँगा? It's already 6 hours, he's not dying. So the relatives are asking him, why did you bring him back from the hospital? He's breathing. So the post decision also, we need to be very, very careful how we take them through. You can't just send them. We need to explain clearly to them what will happen. It may take some time, even 12 hours, 24 hours. So finally, to salvage the situation, I told him, you bring him to the hospital again. So I kept him there for 12 hours, and the patient passed away. So this is also important. Okay, it is not that you've taken a decision, you have done this, but you need to tell them what will happen later. Most of them die within 24 hours. But sometimes you have this phenomenon called a Lazarus phenomenon. Suddenly, though, there is a reflex movement, and all the relatives are around. Suddenly, this person has a fluxion response, and they'll get worried. What is this? Is he coming back to life? And so we have to be very, very careful. They may not be able to understand. Sometimes some of these neurology patients, they have late gasps which can last for 1 or 2 times and few seconds, and then that'll go away. So that may give a false hope, and so we need to give a clear explanation to them.
Thank you. Thank you, sir, for adding that. And I think I would just add one more component, which is the psychological component, because in today's date, I think that is very important, not just like the person who's going through if he's in a chronic condition, but even the relatives and the caretakers, because it's a huge task and a huge burden to take some time, to even make them understand that this transition sometimes is going to be really long and really tough. So places who don't have practical psychological support, either we can train ourselves to do that, or the spiritual counselor can be the psychologist also in that part, which happens in a lot of part in the world. Or else take help from people who are already trained with it, even if it is online or any other in any other form. I think that's also something important that we should add to this whole aspect.
So are there
I just
any?
want to tell, good evening. Yeah. And
Good evening, Dr. N. Please go ahead.
yeah, actually, I just want to tell how I was feeling very bad. My mom was diagnosed to have H4, and 2% she was not able to eat anything, and she said that she doesn't want any treatment and eye fluids. And my father and mother been together for 62 years. And my father was very upset with us that we were not giving her any food, any nutritional support. And he just asked me one thing in my own language. I do not know how to express it in English. I mean, you're putting her to death by not giving her anything, you know. And I felt I couldn't answer father, and I didn't know what to do. I just sat next to him and just cried. So sometimes when your own parents go through, and if the other half is there, the pain that they go through with them is a big challenge.
Yeah, I think I fully understand, and the voice was breaking, but what I understood was that you know taking care of particularly some of the needs, ethically also, nutrition part. Why do why we are not giving them nutrition and
Mm.
yeah.
I think that's what one of my reasons for adding that psychological support to the caretaker, so that the caretaker burden is it's a huge component that needs to be taken care of. I think there was one question in the chat which is very practical also. Dr. Ushma Parik, I think she has asked, what if the reason after ending is monetary? It's a very like a difficult condition. It's more like a dilemma, but yes, there are conditions like that. So do you have anything to add for that?
It's monetary in the sense, I just want to understand. Is it they are not able to afford treatment?
No, I think she means like if there is an aspect in the family that they are wanting to withdraw the life support because they have
Oh,
monetary gains with it.
oh,
Am I
okay,
right,
okay.
Dr. Usha?
Yeah, yeah, yeah. So I think this is also common, but it is tough as doctors. I have got into some of these problems, at least two cases I remember, dementia, and I had managed long ago and documented clearly, but the patient did not die under my care, but later on, then the case came, the property dispute, and I was called to the court, and both the lawyers, the opposition as well as the client, they were all asking me, "Can you confidently say that this person did not have the mental ability to make judgment?" And it is a big thing, I would say. Um, um, yeah, we need to really, I don't know, we may know that for this purpose only they are doing, but oh, we won't be able to change any of those things, and we have to just go with their decision process and take it through, and yeah. Now,
I
for
think informed
some,
consent. Yeah.
yeah,
Sorry.
sorry, yeah,
No, I said maybe just informed consent and written, like
yeah,
whatever we do, expressed at different times. If it is taken in a consent form in a written manner, in
yeah,
the legal aspect, this does definitely saves us from that what
yeah,
you
yeah.
went through, I guess.
There's another thing which I have seen, patient not responding, uh, particularly in the neurology, neuro ICU, they will say, we have to take my mother's pension, father's pension, and so there, it'll be a genuine thing only, but we need to involve the bank, one person representative, and with follow the rules, and we can do that. Yeah.
I think, Abhijit, we're done with the series of questions. Maybe.
Yes, I think there are no more questions, and I think whatever was posted in the registration form, all of them got answered. And I had few of mine. They also got responded even before I asked. So yes, I think there is one more. There's a hand raised. Yes, you can unmute yourself and ask.
Hello. Thank you for a very enlightening and very practical talk. I just wanted to ask, how well do you think our doctors are prepared um, in this area of counseling and speaking to patients about these end of life situations? You are obviously a very experienced person, and one of the things you said is you gain the experience as you go along. But for the patient, that is the only time that they have to, they have to face such things. And so, do you think there is any need for a kind of module, communication module, or some kind of training, special training for these situations on communication? Because it's such an important part of all.
Yeah. No, I think it's a very good question. People, doctors are not, healthcare professionals are not aware. At least from the undergraduation, the MBBS new curriculum, which was introduced in 2019 by NMC, there is an ATCOM module, Attitude, Ethics, and Communication. Ethics is right from the foundation course till the final year. ATCOM that has ethics, communication also. So all these things are taught. End of life care. In our MBBS days or post graduation days, I don't think we had covered any of these. Not even ethics also, and so there's no question about palliative care, end of life care. But with the current new Indian graduates, the ATCOM covers the entire spectrum of all these. And the palliative care, I think some of the PG courses have, and we also have in neurology. It's one of the competencies for DM neurology and maybe I think MD medicine also. So it is inbuilt now. However, on a larger scale, probably we need to create awareness. One for the organ transplant, because for the huge need in our country, the number of organ transplants that are being done, live donor is very, very less. So we all are required to meet that need. And it's not only just doing an organ transplant, but organ retrieval center. If you just need to have an ICU and anesthetist, and you can follow all the procedures for brain dead, and then join the program. So the government has a massive awareness program for this organ donation, and so that is one aspect of it. Second is routine day-to-day affairs that we face uh, with these type of situation. Definitely, there has to be a training, structured training. I think I'm pretty sure CMAI has any modules, any training program.
As per TCB, we definitely have. CMA
Mhm.
also has their portion where they cover.
Okay.
There is a bioethics module for all the 5 sections, all the healthcare cadre for the
Workers.
doctors, nurses, allied health professionals, hospital managers, and chaplains. And apart from that, I think Bangalore Baptist also has come up with a book on communication. So that is also there. These are the resources which are already there within the network. And if you're willing, you can write to us. We'll be happy to share the modules that we have with us, with all of you. Any other questions that are there? So if you have registered, you can also write to us. I'll share my email ID here. My email ID is shared, so you can write to me, and then also write your which healthcare cadre you belong to. Then based on that, we will be able to share the correct curriculum, the correct booklet with you. So if there are no other questions, I think we can conclude the session. And so thank you very much, Dr. Jeyaraj and Dr. Rupa, for this very insightful discussion, and also for sharing from your own personal experience and the way you have learned and how you've experienced and how I have, that's why you are here today and able to share with the rest of us your experience. So thank you so much for your invaluable time, and Dr. Rupa for moderating this vital discussion. And thank you to all our participants for your engagement and the questions that you put. So you can mark your calendars for our next session. We will be moving on to a critical area of modern healthcare, that is law, policy, and digital governance and its implications in healthcare. What we do is usually we have these webinars on Practical Bioethics series on the second Thursday of each month. So in the month of June, it will be, I think it will fall on 11th. So 11th is a tentative date, but the flyers will be out. And if you have registered, you will receive the notification, and you will also receive the flyer and the details. So if you have not registered, what I'll do is I'll share the link again. So you can register. That way we will get your details, and we will be able to send the webinar details with you. So with this, formally we end the webinar, but informally we can continue to just have fellowship. You can open your videos. You can say hello to each other, and just we can leave the room open for maybe 5-10 more minutes. And thank you so much, Dr. Jeyaraj and Dr.
Thank you.
Rupa.
Thank you very much. I really enjoyed it.
Thank you so much.
Thank you. Yeah.
Thank you. Thank you so much, sir.
Bye.
Bye-bye. It'll be good to see some faces. Hello. And, thank you for joining. Thank you all. So see you on 11th of June. Thank you, Dr. Ushma Parekh, for joining in.
My pleasure.
Thank you. The recording will be shared in our website, and you will get a notification of that. Okay, have a good evening. Thank you. Bye. We'll end the meeting now.